Now it's your chance to answer the questions here. These all have answers that go with them. So, okay. Which initial patient presentation is least likely to be associated with minimal change disease? Yeah, again, I'm going to try to cover as much territory as possible. Which is least likely? A 65-year-old white male with AKI and 4+ proteinuria. A 32-year-old white female with 2.1 grams of proteinuria daily. A 45-year-old black male with 9 grams of proteinuria daily. And a 28-year-old white male with high blood pressure, microhematuria, and 4+ proteinuria. So of those, which one are you least likely to find minimal change disease on biopsy? Okay. And we could get some good music like dun, 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 dun. Okay, here we go. Okay, so this is very interesting. We've got a very large splay here. We won't ask you to defend your answers here. The answer is actually the 32-year-old white female with 2.1 grams of proteinuria. So minimal change disease, and again, you've heard about all these diseases today. This is taken from the largest US series. There's one larger Japanese series, but this is the largest US series of adults with minimal change. And we had 95 nephrotic adults here, pretty mixed population here, that the average creatinine was 1.4, the albumin 2.2, the mean proteinuria in these 95 people, this is the mean value, 10 grams a day. There was nobody with 2 grams of proteinuria. Minimal change, I always like to tell our fellows, it's like pregnancy. You either have it or you don't. You don't get a little bit of minimal change. You don't get a little bit of pregnancy. You know, these people get lots of proteinuria. So yeah, you could see 6 grams in somebody, but you're not going to see 2 grams in untreated minimal change. All of the other people had significant proteinuria. And I will say that getting episodes of AKI, acute renal failure, on top of this are quite common in older people with minimal change. Now, what we found was we got identical treatment remissions if we use daily or every other day steroids and exactly the same relapse rates. But we'll come back to that. Question 2. A 38-year-old white female has the nephrotic syndrome due to biopsy-proven minimal change disease. She's responded to a course of prednisone with a complete remission, but has relapsed 3 times whenever she discontinues prednisone. She's steroid-dependent. Which therapy will give her the highest remission rate for treatment at this time in the steroid-dependent person with biopsy-documented minimal change? Is it cyclosporin? Is it cyclophosphamide? Is it tacrolimus? Is it mycophenolate? Or all of the above are equivalent? Okay, do I have a clock here? Does this clock go on, or do I have a timer? No. No, it's not on. I don't know. Okay. No, but you do the question.
Still going.
It's still going. Okay, you guys are voting still. Good. Okay. And the answer is, here we go. Okay. The majority are correct. Now remember, medicine is not a democracy, so if the majority are correct, but it turns out they're all equivalent in terms of if you take people from that same study, we know that. So this shows you steroid-dependent or frequent relapsing adults with minimal change, and you can see complete and partial remission if you add them together. Cyclophosphamide, cyclosporin, tacrolimus, mycophenolate, none of these are significantly different. The major thing is the majority of them will respond, but if you look at it, you're thinking of side effects. If somebody is reason not to get cyclophosphamide, they're 34 years old and they haven't had any kids yet. If somebody has a creatinine of 2 and they don't want cyclosporin or TAC, if somebody's worried about cosmetic effects with cyclosporin, etc., these are the reasons that you use one versus the other as a second-line agent if they're steroid-dependent. Now, I can tell you if they're steroid-resistant, again, it's similar, but the response rate is much lower. Okay, question 3. Which clinical and laboratory features suggest an obese nephrotic patient is more likely to have secondary than primary focal sclerosis. You see somebody in the office, they're grossly overweight, and you say, is this primary? Say they have focal sclerosis on their biopsy. Is black race and 9 grams of proteinuria more likely to be secondary? Is weight race and 3.5 grams of proteinuria per day more likely to be secondary? Is perihilar sclerosis and absence of hematuria more likely? Is a BMI over 40 and a plasma albumin less than 2 more likely to be secondary? Which is secondary focal sclerosis in an obese person? Okay, and you get to vote. Okay, and the majority wins again. White race and 3.5 grams of proteinuria. So it turns out that obesity is very common. Focal sclerosis is turning out to be a very common pattern of the nephrotic syndrome. Here we have one of our obese people. It's an obese person, and they do get obese glomeruli. This is obesity-related glomerulomegaly, and you can see the sclerosis starting here. This is a normal glomerulus, by the way, for comparison. The tubules you can see are the same size. It's just a giant glomerulus. And this will lead to focal sclerosis over time. But they have less proteinuria. They might have 3 grams, 4 grams. They have more close to normal albumins, and whites are more likely to have, it's not that whites are more obese. There are obese whites, there are obese blacks, there are obese everybody. But it turns out focal sclerosis is predisposed. Primary is much more common in blacks than whites. And this just shows you again, obesity-related glomerulomegaly. Here's giant glomerulus with focal sclerosing lesions. Here's another big glomerulus here, etc. Okay, question 4, straightforward. Which genetic defect that leads to focal sclerosis is not associated with autosomal dominant inheritance? Is it alpha-actinin 4, inverted formin 2, Podocyte, TRPC6? Now, there are many different exotic and rare forms of inherited focal sclerosis. These are probably the 4 most common, and one of them is not an autosomal dominant. So which is that? These are supposed to be like board questions. I mean, that's the kind of thing they could ask. Okay, and it's interesting. I have 1, 2, 3, 4, but the majority are right. It is C. Podocyte. Podocyte is a recessive, so it's an autosomal recessive. The others are all autosomal dominant. And again, you'd expect multiple family members. In a recessive, you're going to expect less. But it's worth knowing in terms of which are dominant because what you're going to look for in the family. Now, none of these are phenomenally common in adults, but in kids, yes, they are. So alpha-actinin 4, familial autosomal dominant, Podocyte, the MPHS2 gene, autosomal recessive, steroid-resistant nephrotic syndrome, TRPC6 channel defect, dominant, inverted formin 2, autosomal dominant, which may be the most common, actually, it turns out. Which statement is not true about the incidence of focal segmental sclerosis? The incidence of focal sclerosis is increasing in the U.S., and it is the most common pattern of idiopathic nephrotic syndrome in blacks. Now, which is not true? The incidence of focal sclerosis is increasing in Caucasians in the U.S. The incidence in most other Western countries is just as high as in the U.S. Focal sclerosis is the most frequent form of idiopathic nephrotic syndrome to lead to end-stage renal disease. 3 of these are true, 1 is not. Okay, well, we have a close race here, okay? So some people think 3, some people think 4. Now, some people guessed E, which is 5, but there is no, unless there's something off this slide, okay? So it turns out the incidence of focal sclerosis is increasing. It's the most common in blacks. It is increasing in whites as well. The incidence in most Western countries is not as high as the U.S., and it is the most frequent form of idiopathic nephrotic syndrome to lead to end-stage renal disease. This just shows you a study from University of Chicago looking at the incidence of focal sclerosis over 20 years. Look at that increase from 4% to 18% of all native kidney biopsies, as opposed to membranous and minimal change, which are absolutely static over the time. If you look at other countries, Spain, Italy, Denmark, etc., there is a significant incidence of focal sclerosis here, but it's nowhere near what you see in the United States. You're not going to see 20%, and 20% of the nephrotics in the United States will have focal sclerosis. A lot of places, it's even more. Here's the Toronto Registry. Remember we said before, everybody gets entered into the registry. Look at the incidence of focal sclerosis. These are the number of biopsies. Look at how it goes up, up, up. Let's look at membranous as the control. Constant, constant, constant over time. And the focal sclerosis goes up, up, up. Why is that? We don't know. Now here's a study from the Mayo Clinic. It's only biopsies in Olmsted County, Minnesota, okay? Olmsted County has one city, Rochester, Minnesota. It has one thing in it, the Mayo Clinic. So if you just take that county, you know, where everybody, I put down over 90% are Caucasian, but, you know, Fernando Fervenza would say, oh no, Dr. Appel, not 90%, 98% are white. If you look at that, that's their incidence of focal sclerosis, 74 to 83. 10 years later, 17%, 94 to 20%. And the same thing is true in New York City. A former fellow of mine works at a hospital that is largely a Caucasian population. The incidence has gone right up. So it's increasing in whites as well, and we don't know why. Okay, which therapy has been studied in a randomized control fashion in adults with focal sclerosis? IV cyclophosphamide, cyclosporin, rituximab, ACTH, which has been studied in a randomized control fashion in FSGS. Okay? I think we're going to do well on this one. I feel it. Yes. Okay. So cyclosporin, of course, has been studied in a randomized trial. So PO cyclophosphamide has been studied in kids, but not IV. Rituximab has not been studied, and ACTH has not been studied. It's actually going to be studied now. This just shows you the North American collaborative trial here in terms of cyclosporin for focal sclerosis. This is placebo with a very low dose of steroids. This is cyclosporin with the same low dose of steroids. You're talking about complete and partial remissions here. You stop therapy at 26 weeks, and even way out at 104 weeks, you still have more people in remission. And if you look at the percentage who had a decline in creatinine clearance, the placebo group was losing renal function much faster than the cyclosporin group. Now, there is a trial of mycophenolate versus cyclosporin. Here you're looking at the change in proteinuria. It's greater with the cyclosporin than with the mycophenolate, but the change in GFR is also more. At the end of the study, about 25% of the patients had a complete remission in each group. So it came out about the same, but the recruitment was much lower. It was a pediatric study. They allowed people up, we had like 9 patients at Columbia. They were all adults, but it was still underpowered grossly. Even though KDIGO says you can use mycophenolate, this is not a good enough trial to say that it's right up there with cyclosporin. It's not a randomized controlled trial that had enough patients to show a statistical difference. Okay, I won't go through rituximab. ACTH, this is the only, as a former fellow of mine, well, actually, he was a fellow when we did this, but essentially this is a study we did at Columbia and with Stanford, with Rich Lafayette, and we had 7 of 24 patients who were multi-drug resistant who responded to ACTH gel. But again, you know, I don't know, is that good or bad? It's 7 of 24. Okay, which is a common feature of idiopathic membranous? Calcium oxalate stones, uric acid stones, renal vein thrombosis, struvite stones. Got some magnesium ammonium phosphate or struvate stones. There we go. Okay. So somebody got the message, like in, Larry Beck's talk before. Clearly, renal vein thrombosis is the answer here. And again, everything tips towards the coagulation system here. DVTs, deep vein thrombophlebitis, renal vein thrombosis, pulmonary emboli are all common, but they're much more common in membranous than any other form of the nephrotic syndrome. Now, renal vein thrombosis is often asymptomatic, by the way, but you can get flank pain, microhematuria, gross hematuria even rarely, and a decreased GFR. Here's what used to be the gold standard for this. This is a venogram, an inferior vena cavagram. We've injected contrast here into the vena cava here, that here's the radicals of the lower pole of the kidney. Look at the upper pole. Here's the filling defect, and you can see it's going right into the renal vein here, renal vein thrombosis. Here's a CAT scan, normal kidney, normal renal vein, swollen kidney, clot going right from the renal vein into the vena cava. And sometimes you don't even need that. This is a patient with known membranous nephropathy admitted to 2 New York City hospitals with cough, shortness of breath. Both times they diagnosed pneumonia, treated her with antibiotics, and sent her out. She had dilated veins all the way from the hypogastric up to the iliac. Here are these giant veins on the side. You can see she had total right renal vein thrombosis, partial inferior vena cava thrombosis. So always think of it in membranous. The lower the serum albumin, the heavier the proteinuria, the more likely you are to get it. Whether you use 2.8 or you use 2.6 or 2.4, it doesn't make a difference. The lower it goes, especially when it's down in that low 2 range, that's when the risk goes way up. Okay, now this is a question we should do very well on because Larry Beck put this in a different way. Which features on the biopsy of a patient with membranous nephropathy suggest a secondary form of membranous other than primary? Yeah, I could have been put in staining for the phospholipase A2 receptor, but everybody would get that right. If you're positive, you have primary, and if you're negative, you're likely to have something else. But what about if they don't do staining? A lot of people don't get staining for the phospholipase A2 receptor routinely. So segmental scars, is that secondary? Mesangial deposits, is that secondary? Global glomerular sclerosis, is that secondary? Subepithelial deposits without spike formation, is that secondary? Which one suggests a secondary form, such as lupus, medication-related, hepatitis B-related, etc.? Actually, Larry had this on a slide. And there we go. And the majority are correct. Okay? So you can have stage 1 membranous with subepithelial deposits, and you don't have the spike formation. It's not the most common pattern, but you can have it. Mesangial deposits should always suggest looking for a second form. So if you have mesangial deposits and you have a young lady, you're thinking, could it be lupus? Especially looking if it's full house staining. But the mesangial deposits are a tip-off. And since Larry said it and I said it, it must be important. Okay. Here's a biopsy. Let's say they show you this on your board exam, this biopsy. Which test is usually not part of the evaluation for the kidney biopsy that's shown here? Is hepatitis C and B serology not part of the evaluation? SPEP, UPEP, free light, ANA, total complement, anti-GBM antibody. Which would you not do? Now, some of you would just say, screw it, I'm doing all the serologic tests, but there are reasons to do them. I mean, there are some things you need to do and some things you don't. Okay, yes, indeed. Now there's 2 good things. Nobody said C, even better, nobody said E, but the very important thing is 81% are correct. You wouldn't do an anti-GBM antibody titer. This is clearly a membranoproliferative pattern. It's lobular in nature. That goes with membranoproliferative. There's double contours. Let's see if I can get that here, of the basement membrane here with mesangial interposition here. Again, you can see that in a number of places. And again, the double contours here. And this could be hepatitis C, less commonly hepatitis B. It certainly could be going along with a monoclonal disease. It could be a lupus MPGN pattern, but it's not going to be anti-GBM disease. The hallmark of anti-GBM disease is extracapillary proliferation crescents. You see no crescents in Bowman's space here. Again, you're just not thinking of anti-GBM disease. It would be reportable. Which therapy has not proven effective in inducing remissions of the nephrotic syndrome in a randomized controlled trial in membranous? Which one has not been shown in a randomized trial? Is it TAC? Is it alternating months of steroids and cyclophosphamide? Is it ACTH? Is it rituximab? Okay, and the majority is doing very well here. I don't know who you are out there. You're not even, you are the silent majority, but you answer your keypads. So it turns out that TAC has been shown, Manny Praga has shown that in a study. Of course, the alternating months of steroids and cyclophosphamides is the classic Ponticelli regimen. I mean, Claudio Ponticelli has done a lot more in nephrology, but that's where his name is stuck. ACTH has been shown. Ponticelli showed it himself, that if you use ACTH, you get the same results as his regimen. Rituximab is currently being studied in the Mentor trial on 150-something patients. All 150 are enrolled. They'll have completed the first year of therapy in September here. That is rituximab versus a calcineurin, cyclosporin. Now, I'm not going to go through the old data here, but I just would show you the ACH trial. I want to point out it is Ponticelli who did this. Here's their proteinuria in his group that got his regimen, 4 to 10 grams of proteinuria per day. Here's after therapy, complete partial remissions. Here's 4 to 13 grams a day. They get ACTH, complete and partial remissions. So again, that is a controlled randomized trial by Ponticelli. Which statement is true about the use of rituximab in large controlled randomized trials of glomerular disease? Rituximab has proven effective in diffuse proliferative lupus nephritis. Rituximab has proven effective in ANCA-positive vasculitis. Rituximab has proven effective in membranous lupus nephropathy. Rituximab has proven effective in steroid-resistant focal sclerosis. Now, we would like 100% on, this is my best guess for 100%. Somebody will guess E. No, okay. Whoa, we were doing better and we're going, stop it before they keep changing their mind. 77% is the best we can do. So right now, rituximab is the only FDA-approved therapy for ANCA-positive vasculitis. Remember, cyclophosphamide is not FDA approved. It was just grandfathered in. But rituximab is FDA approved. And that's the reason you have the least trouble with insurance companies. You know, if they say, we want you to use cyclophosphamide, and you say, I'd rather use rituximab, and they say, no, we want you to use cyclophosphamide first, you tell them, well, it's not FDA approved. We'd rather use the FDA approved regimen. And if you don't want us to use the FDA approved regimen, we're putting your name in the chart saying we want the other regimen first. You know, and the insurance companies always back down. In the LUNAR trial, rituximab was not effective in diffuse proliferative lupus, so that's the only large control trial. In membranous lupus, again, there is no big study that shows it works, and in focal sclerosis, it hasn't been studied. We're not going to go through the RAVE trial again. Okay. 22-year-old white male is seen with a creatinine of 1.8 and 2.4 grams of proteinuria daily. On physical examination, he has the following skin changes here. So you see these skin changes in a 22-year-old with 1.8 milligrams creatinine and 2.4 grams of proteinuria. And you think this is going to be an easy question. Okay. Which would not be a typical finding in this patient? Is it eye changes, acroparesthesias? This, I'll give you a hint, it's an electron micrograph biopsy, or this electron micrograph biopsy, which would not be expected to be found in that person with those skin changes and a creatinine of 1.8 and 2.4 grams of proteinuria. I think 77% is the best we've done so far. Seems like we're waiting an unbelievable long time. It was a tough one. Okay, this is good. 56% are correct. Okay, so now of course the question is, what are these? So these are this is Fabry's disease. Okay, so that's classic skin findings for Fabry's in the bathing suit area. If you have somebody, especially males, because it's X-linked, if you check their bathing suit area, you may see those little angiokeratomas here. They often get acroparesthesias. They also get lack of sweating that they get on their kidney biopsy. Here you're looking at a glomerular capillary loop and the glomerular basement membrane. Here's another. Here's the podocyte. It's filled with zebra bodies. That is classic for Fabry's. This biopsy, capillary loop, here's your basement membrane. Here are the podocytes. You don't see any zebra bodies. You see laminations of the basement membrane. This is Alport syndrome. So the 57% of you, I hope you recognize this as Alport syndrome, which again is another common disease, genetic disease, that if you had to pick two genetic diseases that you wanted to know about, Fabry's and Alport's would probably be the two. Okay, a 22-year-old with a 2-year history of proteinuria and hematuria has this biopsy. Here's the light microscopy. Here is the electron microscopy, which is not likely to be found with this lesion. Positive ANA, C3 nephritic factor, low factor H, low C3 level, which is not likely to be found. So again, this is what they often ask on board questions, by the way. They give you something, you have to understand what it is, but then you have to answer something else about it. So the majority is doing terrifically here. We can't get 90% of you, but we're getting in the 50%. A positive ANA is very unlikely. So if you look at this biopsy, what do you see? You look at this one glomerulus, and you only have one here. First of all, it's broken into lobules. The old name for MPGN was lobular glomerulonephritis. So you're guessing that it's going to be an MPGN. Then you look again, and you see it's proliferative. And you can see the double contours here again. So seeing double contours, this is an MPGN pattern. Regardless, if you look at the electron microscopy, here is this dense ribbon of electron-dense material all along every capillary loop here in the basement membrane. This is dense deposit disease, which is one of the C3 glomerulopathies, dense deposit disease. And a lot of the patients will have a C3 nephritic factor. Many will have a low factor H. Factor H deficiency is common, and they'll have a low C3 level. So again, you have to recognize this because it's becoming an important disease. Now, we said here's another one. Look at the lobular nature here of the glomerulus and the proliferation here. You get C3 deposited, but there's no immunoglobulin. There's no IgG, there's no IgA in here. This is just C3. That's what's in these electron densities here. Normally we think of the electron dense deposits as immune complexes. Here you're seeing C3 and C3 breakdown products that are in here, complement breakdown products. The other one of the C3 glomerulopathies is C3 glomerulonephritis. Little bit of proliferation, only C3. Here you see some electron-dense deposits, but you don't see that dense ribbon here, but it's the same pathogenesis. So the classic pathway is set off by immune complexes. And typical disease, post-strep or lupus, etc., it goes through C1 to the C3 convertase. The alternate pathway goes directly through C3, but they all go down here to the membrane attack complex, C5b through 9, and produce the anaphylatoxin C5a. Again, here you're triggered by antigen-antibody complexes. Here, the C3, the alternate pathway, is always on at a low rate. But if you're missing inhibitors or you have something that accelerates the pathway, you will go on and get dense deposit disease or C3 nephropathy. And again, the way to look at it is, if you saw an MPGN pattern in the old days, you might talk about type 1, type 2. We don't talk about that anymore. If you see immunoglobulin G or IgM, etc., you're thinking of MPGN type 1. If you see C3 without IgG or any of them, it could be MPGN type 3, which is largely these, or it could be C3 glomerulopathy. But again, they only have C3 deposited. Okay, a 32-year-old white male ex-IV drug abuser presents with edema. He has a normal blood pressure. His physical exam is normal except for a 2/6 systolic ejection murmur at the apex and a non-blanching purpuric rash on his legs. He has a serum creatinine of 1.8, dysmorphic red cells. He has a glomerular disease, 3.6 grams of proteinuria. The following tests are negative. ANA, ANCA, ASLO, SPEP serum total complement is markedly reduced with a normal C3 and a low C4. Ultrasound reveals normal-sized kidneys with increased echogenicity. So he has a low complement, but a normal C3 level. It's mostly C4. What is the most likely diagnosis? By the way, this is his rash on his lower extremity, non-blanching rash. Is it HIV nephropathy? Is it MPGN due to hepatitis C? Is it proliferative GN due to SBE? Is it AA amyloid? Not the easiest question, but here we go. Okay, so the good thing is those were the two diagnoses that were of most concern. And the reason I put this on is it turns out it's MPGN due to hepatitis C. That is the classic rash of this with this discoloration. But the important thing is C4 is low. Post-infectious glomerulonephritis, whether it's due to SBE, whether it's due to post-strep, whether it's due to deep-seated abscess, usually the C3 is lower and the C4 is normal. It usually triggers the alternate pathway in terms of, so you get this. So again, the post-infectious usually gives you at least a lower C3 than you do the C4. In lupus, you get both C4 and C3 low. In MPGN, due to hepatitis C, and usually associated with cryos, C4 is the lower one, and C3 is normal. So the complement can be helpful in terms of those things. Okay. 27-year-old stock analyst has had 3 spontaneous abortions. She has Raynaud's phenomena. 2 years ago, she developed a DVT of the calf after a long auto trip. She develops arthralgias, low-grade temperatures, and malaise. She's hypertensive. She has a malar thrush. She has a systolic ejection murmur, swollen hand joints. She has lividoverticularis of the legs and 2+ ankle edema. She has a low white count, a low hematocrit and hemoglobin, and a low platelet count. 3+ proteinuria, 3+ hematuria, red cells and red cell casts. She has a glomerular disease. BUN is 43, creatinine is 2.6. 24-hour protein is 1.2 grams per day. Her PT is 14.6. Her PTT is 85. ANA is positive. Anti-double-stranded DNA is negative. C3 and C4 are only borderline low. The biopsy is most likely to show which of the following: diffuse proliferative lupus nephritis, focal proliferative glomerulonephritis, thrombotic microangiopathy, membranous lupus. Now this is really a guess because you'd have to do a biopsy to prove this, but you've got a bunch of things going in the same direction here. Are we close? Yeah. Okay. Thrombotic microangiopathy is correct, and we're getting a good number of you who've got that. So antiphospholipid antibodies are a family of antibodies against negatively charged phospholipids, includes the lupus anticoagulant, anticardiolipin, and they obviously, even though we talk about the lupus anticoagulant, they have a procoagulant effect, and a thrombotic microangiopathy is what you would see. And here's somebody who had a DVT before. They have livedo reticularis, which is the one physical finding that goes with anticardiolipin syndrome. They've had 3 spontaneous miscarriages or spontaneous abortions before. They have a classic picture for this. Here you can see the most common things that you find: DVT, thrombocytopenia, livedo. Renal manifestations are only a minority if you take all the people with antiphospholipid syndrome, but again, she's one of them. This is the livedo reticularis, this dilated venous network below the surface of the skin here. Looks like a web-like pattern. When you see this, at least think of antiphospholipid syndrome. Okay, question 17. A 75-year-old white male presents with a 3-week history of low-grade fever, malaise, and a petechial skin rash. Biopsy of the rash shows leukocytoclastic vasculitis. Creatinine is 4.8. He has 2.4 grams of proteinuria with red cells and RBC casts. MPO ANCA is strongly positive. The biopsy shows a crescentic glomerulonephritis with no IF staining for immunoglobulins or complement. EM is pending. Which statement is true about the treatment of this patient? PO cyclophosphamide is superior to IV cyclophosphamide in inducing remissions. IV rituximab and PO cyclophosphamide are equally effective at inducing remissions. IV rituximab is superior to IV cyclophosphamide at inducing a remission. If effectively treated, he will have a low morbidity and mortality from therapy. Okay, and the majority wins again. But we've got a little splay here. So it turns out PO and IV cyclophosphamide are really equivalent. The Cyclops study showed that they're really equivalent in this. I mean, you get more little induction, but you get more in terms of relapses. IV rituximab, if you're talking about the RAVE trial, it was IV rituximab versus PO cyclophosphamide, not IV. It was PO followed by azathioprine. Remember, the rituximab arm got nothing after the rituximab. So that is indeed true here. IV rituximab is not superior to IV cyclophosphamide because it hasn't been compared to it. And if effectively treated, even if you got this guy with good therapy and everything, he has a very high mortality because he's older and he has renal insufficiency. If you take all of the Eurolupus studies here and look at mortality, the older the age, the lower the GFR, the higher the mortality. And again, that's always true. So if you take people in their 70s, you're going to have a higher mortality. Now, we actually did a study on this. We looked retrospectively. If you didn't treat them, they all died. So that doesn't mean don't treat them, but you have to expect a higher morbidity, mortality, and be judicious in people with decreased GFR, especially if it's very low and if they're older. Question 18. A 4-year-old white female goes to a petting zoo with her parents. She cuddles the sheep, calves, and other baby animals. She does not wash her hands. 3 days later, she develops abdominal cramps, diarrhea, and bloody stools. She has nausea, vomiting, and fever. She's given an antibiotic by her pediatrician. 6 days later, there are ecchymoses on her extremities and lips, thrombocytopenia, oliguria, and seizures. Her stool is positive for E. coli 157H7. Which therapy has proven effective for this disease? IV quinolone antibiotics, plasma exchange therapy, Synsorb, the shigatoxin binding agent, eculizumab, none of the above. I'm not sure how we're doing on timing. We're okay because we started the clock late, but okay, none of the agents again. We've got a great majority here. So all kinds of things have been tried in terms of this. But again, no matter what's been looked at, the eculizumab, we thought that this was going to work in terms of when it started out, when there was the epidemic in Europe, when they had the sugar toxin that related HUS. But again, nothing has actually worked. Petting zoos are a big source of problem now because, again, the animals are large. There are many animals infected, and if the kids don't wash their hands or wipe their hands right away, they're in trouble. My daughter-in-law would not let us take the grandkids when they were little to a petting zoo without sending us along with bottles of Purell and wipes and all kinds of things for their hands, our hands, and everything. But it's a good idea because in that epidemic, there was an epidemic in Florida, and a bunch of the kids died, actually. This is the Florida officials here. 15 cases of kidney disease. 3 of the kids died from this. So this is really, again, a big concern if you're taking your kids or grandchildren to a petting zoo. What you see in HUS is micro-thromboses here in the glomeruli, okay? And you get a microangiopathic hemolytic anemia, and of course the stool is positive. This was a Newsweek article. Can this meat kill you? The E. coli is at its worst. I was giving a talk on thrombotic microangiopathies in Toronto. This is the Toronto Globe, and that day it came out. Consumers warned not to eat fresh spinach imported from the U.S. Quarantine in terms of this. There's always an epidemic. Every year in the summer there's an epidemic. We haven't had one yet this year. You'll see it. It'll come. Okay, question 19. We're almost there. A 36-year-old previously healthy black female develops fever and bruising. She goes to her local doctor. Her CBC shows 15,000 platelets. She's anemic with a hematocrit of 28. She has a normal PT and PTT. The smear shows a microangiopathic hemolytic anemia. Over the next few days, her urine output declines, and she develops sudden blindness followed by decreased mental status. What should you do next? Send for an assay for the metalloproteinase ADAM-TS13. Institute immediate plasma exchange and steroids. Institute immediate heparin and start Coumadin anticoagulation. Start rituximab and steroids. Looking at the question now, it's sort of a stupid question in some ways, but, Okay, but 81% agreed with me at least. Okay, you'd probably, with one hand, you'd send for the assay for ADAM-TS13. With the other hand, you'd say, order plasma exchange and steroid therapy, because of course, if you're looking at TTP, that is the treatment of choice here. That rituximab is used for treatment failures, but again, first thing you want is plasma exchange here. You want to remove the large von Willebrand factor multimers, etc., and of course, you want to replace any ADAM-TS13 that's missing. Okay, last question here. A 62-year-old white male plumber with mild hypertension is evaluated for proteinuria and edema. His blood pressure is pretty good. He has an S4 cardiac gallop, no hepatosplenomegaly, 2 to 3 plus pedal edema. His BUN is 12, his creatinine is 0.7, his urinalysis has 4 plus proteinuria, 2 plus hematuria, and 4.2 grams of proteinuria. ANA complement hepatitis B, C are all negative. His SPEP shows a 1.8 gram spike of IgG kappa, and his serum albumin, his plasma albumin, is 2.2. So I want to go over this before I switch. 62-year-old plumber with BUN of 12, creatinine 0.7, 4 plus proteinuria here, 2 plus hematuria, 4.2 grams of proteinuria, and an IgG kappa spike. His biopsy might show all of the following except which one? This is your last chance to get 100%. So all of you who were guessing E before, put your minds to it. Now you should easily recognize 3 of these. The 4th, I admit, may be a little problem, but it's... but it's still easy to get the answer, we think. Okay, so the majority again wins. So what do we have here? We have somebody who has the nephrotic syndrome. We know they have a significant amount of proteinuria. The dipstick is 4+ positive for protein. The dipstick only picks up albumin. It doesn't pick up light chains. So you know that 4-something grams of protein is albuminuria. He has the nephrotic syndrome, and he has it with an IgG kappa spike. Here in panel 1, we see amyloid. We see every capillary loop wall here is thickened by a glassy eosinophilic material here. No increase in cells. You can tell by nuclei. The eosinophilic material goes here. It's from the afferent arteriole here, going right into the glomerulus. Clearly amyloid. Yes, he could have amyloid. 2, this is light chain deposition disease. Some people used to call it kappa chain disease because it's much more common with kappa. Lambda is much more common with amyloid, and kappa is much more common with monoclonal immunoglobulin deposition disease. Every capillary loop is stained positive for kappa here. So is Bowman's capsule. So is every tubule. Everything stains. Yes, he could have that. 3rd, he could have a monoclonal immune complex GN here, electron-dense deposits here, proliferative GN with a monoclonal protein. This is turning out to be much more common than we thought. And you know, in some series, it's greater than light chain deposition disease. What he is not going to have is myeloma cast nephropathy, light chain cast nephropathy. And here you look at these are tubules. These are classic for light chain cast nephropathy. Here's a cast that's fractured as if somebody hit it with a hammer and burst into pieces. Here's a multinucleated giant cell. Here's laminations of the wall of the cast. You can see different layers. All of that tells you this is light chain crystalline deposit here. This goes with AKI. His creatinine's normal. He has a glomerular disease. So, congratulations to the majority of you, which I have a feeling is not just the same 57 or 68%. I think, you know, it gives you an idea of where you have to work on things that, and I think I've already told you more than I know about the subject at this point.